Hello guys, so welcome to today's class. Just give me a quick confirmation on the live chat that I'm audible and I'm visible. Just give me a quick confirmation, then we'll start today's class. Am I live? Just give me a quick confirmation, guys. यार हुआ नहीं है भाई लाइव आ रही है आवाज I can't see. Yeah, I think we are live. Yes, I can see. So hi guys, so welcome to today's class. Hello Medicals Journey, good evening. Good evening, how are you? Good evening. So today's class is gonna be a clinical masterclass, and what other clinical masterclass do you need other than how to read a chest X-ray, right? Because chest X-ray is the basic investigation that you as an MBBS student need to know and have to know, right? Because you will be posted independently in PHCs during your internship, and you will be working as medical officer after your internship. So you need to know how to read a chest X-ray, right? And so in today's class, we'll touch upon the basics of how to read a chest X-ray. And in the subsequent classes, yes, we can take an advanced class of what are the various different pathologies. Some of the pathology I'll cover in today's class also, but detailed class we can have another class. So this is how long will be the class? This will be for 1 hour. We'll finish the class at 7 p.m. sharp, right? Thank you. So, without further ado, let's start with today's class, how to read a basic chest X-ray. Now, this is a normal chest X-ray that you guys are given in the exam, and sometimes in the exam and sometimes in real life also, right? So, before jumping into the diagnosis, we first have to identify what is the quality of the film, because quality determines whether we'll be able to interpret this X-ray or not. So first thing that we see are the patient details. Now, where are the patient details usually written? They're written on the top hand side right here. So let's say the patient's name is Dhriti. Dhriti is a 25-year-old female. Her ID is 1234567891090. This is her ID. And next thing they write about the when is the date of acquisition. So today is 7th. So 07/2025. This is the patient details. Normally they should not obscure any part of the lung, right? They should be outside the lung fields. But for demonstration purposes, I have written like this. So first thing are patient details. This tells you a lot that what is the patient's age and what is the patient's sex. This is very important because a lot of pathologies are different in children and different in adults. Second thing, it tells us when was this acquired, because temporal correlation of a lot of pathologies is needed. For example, there is a pneumonia. On day 1, you see a big patch of pneumonia in the right lung and you start antibiotics. Now, serial follow-up x-rays are done to see whether this patch of pneumonia has resolved or not. So the date when the x-ray is acquired is also very important. Hello, Dr. G. Hello, is it effective for NEET PG? So person, not a very high yield class for NEET PG. If you are a NEET PG student, I wouldn't really recommend that you watch this video because we'll go very slowly from the basics. It'll आपका बहुत सारा time waste होगा अगर आप NEET PG point of view के लिए पढ़ोगे. If you're an MBBS student, this is the class for you, not particularly for a NEET PG student. Moving on. So first is patient detail. Next is quality of film. Now, quality of film we determine by a mnemonic known as RIPE. Right? Now, what does R stands for? Just give me a minute. So, R stands for rotation. Rotation of film. I stands for inspiration. P stands for projection. What do I mean by projection? Whether this is an AP film or a PA film. AP view versus PA view. And E stands for exposure. Right? So RIPE is an important criteria where you assess the quality of film. So even in the exam, when you're given a chest x-ray, before saying that this is a chest x-ray of a pneumonia, you say that this is a PA view chest x-ray of a 25-year-old female. I can see that the film is not rotated. It is taken in adequate inspiration with optimal exposure. So this is a first line of your description of your x-ray. Whenever you are given an x-ray, say the patient's age and sex. This is a chest x-ray, PA view of a 25-year-old female. The film is not rotated. It is taken in adequate inspiration with adequate exposure. Right? Now, how do we assess these four things? Rotation of the film. Now, rotation of the film is assessed by taking into account the distance of the tips of the spinous process. Where are the spinous processes? So this is the trachea. Can you see this air column? This is the trachea, and through the trachea you can see these white color rounded or oval structures. These are nothing but the spinous processes of the thoracic vertebrae. So you draw a line intersecting all the thoracic spinous vertebrae, thoracic vertebrae spinous processes. Now this forms the midline of your patient's body. This is the midline of the patient, and from this line we assess. I'll remove this. From this line we'll assess the distance of the medial ends of clavicle. This is the medial end of clavicle, and we assess this distance, right? A and B. So on the right hand side, the distance from the medial end of clavicle to the midline is A, and on the left side it's B. Now this should be equidistant, that is A should be equal to B, and we say that the medial end of clavicles are equidistant from the midline, and this tells us that the film is not rotated. So rotation हम देखेंगे medial end of clavicle से equidistant होना चाहिए. इसका मतलब है कि हमारी film rotated नहीं है. Second was I, inspiration. Now a normal chest x-ray is taken at end of inspiration in PA view. एंड ऑफ इंस्पिरेशन इन पीए व्यू लेते हैं हम. एंड ऑफ इंस्पिरेशन कैसे? पेशेंट को बोलते हैं रेडियोग्राफर, लंबी सांस लीजिए, रोक के रखिए, एंड देन ही प्रेसेस द एक्सपोजर बटन. सो इट इज टेकन इन एंड एक्सपिरेशन. नाउ हाउ डू वी असेस दैट इट इज end inspiration, not expiration, end inspiration. So anterior ribs should be 6th to 7th above diaphragm, and posterior ribs should be 8th to 10th above diaphragm. Now how do we measure and how do we see the anterior and the posterior ribs? So ये वाली जो आपको ribs दिख रही हैं, these are all posterior ribs. So this will be rib number 1, 2, 3, 4, 5, 6, 7. These are posterior ribs. 8th, 9th, 10th, right? These are posterior ribs, posterior part of the ribs. And where are the anterior ribs then? This is your anterior rib. So this is rib number 1. This is rib number 2. This is rib number 3, and so on and so forth. 5, 4, 5, 6. So I can see that above the diaphragm, 6th anterior rib and 10th posterior rib is there. That means it is taken in end inspiration. That means it is an adequately inspired film. It is taken in the adequate inspiration. Second was I for inspiration. Third is projection. AP versus PA versus AP. Now how is a PA radiograph taken? and how is an AP radiograph taken. Now, PA stands for posterior-anterior, meaning that the rays are coming from behind and the cassette or the film is in front, right? So, patient hugs the bucky, hugs the detector, rays are coming from behind. Now, he hugs the bucky like this. So, what happens? The scapula come out. In a PA view, the scapula will come out, and since his hands are raised, the clavicle will be at the top of the lung. So you'll see some part of the lung above the clavicle in PA. Sorry, since his hands are like this, some part of the lungs are above the clavicle. So in a PA view, what happens? The scapula are out. So you will see that the medial end of the scapula is outside the lung field. Number one point is PA view, scapula is deviated outwards. And number two, clavicle beneath the lung apex. Right? Whereas in a PA view, what happens? The rays are coming from the front, the detector is at the back, पीछे है detector. So patient keeps his hands like this anteriorly. Rays are coming from the front. So what happens? Since the hands are on the side of the patient, the scapula का medial border अंदर की तरफ होता है. देखो lungs को overlap कर रहा है scapula का medial border. और जो ribs हैं, जो clavicle है, clavicle जो है, it is at the top of the lung fields. Clavicle is at the top of lung fields. So what are the difference in AP view? Scapula medial border overlaps lung fields. ठीक है, ये स्कैपुला है हमारा, ये स्कैपुला है, this is overlapping the lung fields. And second, clavicle at the top of lung apex. Clavicle is at the top of lung apex. So these are the two important differences between PA and AP. Another difference that people tell is with regards to heart size, that in AP the heart size is a little larger because the detector is farther away from the heart, but that you can't appreciate on a single radiograph, right? You need two comparative radiographs to say which is AP or PA. So for single radiograph differentiating AP or PA, just look at the scapula. Scapula is most important. In PA view, the scapula is out because patient is hugging the cassette like this. This is most important. So third is projection. And what is the fourth part? In right, fourth was exposure. ठीक है. So exposure was the term that was earlier used जब स्क्रीन कन्वेंशनल रेडियोग्राफी होती थी कि फोटो खींचती थी, आप एक्सपोज करो और पीछे वाली जो फिल्म होती थी वो एक्सपोज होती थी. आजकल डिजिटल रेडियोग्राफी होती है. सो इन डिजिटल रेडियोग्राफी एक्सपोजर टर्म इज नॉट रियली इंपॉर्टेंट बिकॉज विंडोइंग कर सकते हो आप यहाँ पे. बट व्हाट हैपेंस, हाउ डू यू असेस एक्सपोजर? यू से दैट बिहाइंड द हार्ट शैडो, ये हार्ट शैडो है, behind the heart shadow you should be able to see intervertebral discs. देखो, if I zoom, are you able to see these black lines? These are nothing but intervertebral discs. So दिखनी चाहिए, they should be visible on a PA X-ray, PA chest X-ray, and that's how you say that the exposure is adequate. So exposure के लिए हम क्या लिखेंगे? Exposure, intervertebral discs should be visible behind heart shadow. Is radiographer important in the medical field? Yes, radiographers are very important. They are the ones who acquire the images. Radiologist reports these images, but acquisition is done by radiographer. ठीक है. सो पहला क्या था? रोटेशन, फिर इंस्पिरेशन, प्रोजेक्शन एंड देन एक्सपोजर. नाउ लेट्स अंडरस्टैंड द anatomy of the chest x-ray also. Let's understand the anatomy. So from above downwards, we have trachea, this black structure which is dividing like this. This is the trachea, and it divides into the right bronchus and the left bronchus. So you have to comment whether the trachea is in midline or is it deviated, right? So the first line that we'll write on chest X-ray report is trachea is in midline. Trachea is in midline. Now after that, we'll assess the heart shadow. Now when we see the heart shadow, this is the heart shadow on the right and on the left. Now what are the parts of the heart? Which structure forms which border of the heart? So on the right hand side, above is the SVC, then the right atrium, and lower this small छोटा सा part होता है IVC का. On the left hand side, we have the aortic arch, the main pulmonary artery, the left atrial appendage, and the left ventricle. Right, these are the structures from the heart body. So second thing we'll write about is कार्डियक सिलुएट. सिलुएट का मतलब होता है परछाई, शैडो. कार्डियक सिलुएट इज नॉर्मल इन पोजीशन एंड साइज. नॉर्मल इन पोजीशन साइज. पोजीशन का क्या मतलब होता है कि जो कार्डियक एपेक्स है इट इज पॉइंटिंग टू द लेफ्ट हैंड साइड. कार्डियक एपेक्स इज पॉइंटिंग टू द लेफ्ट हैंड साइड. दिस मीन्स दैट दिस इज लीवोकार्डिया. अगर यही उल्टी हो जाए, हार्ट कार्डियक एपेक्स इज पॉइंटिंग टू द राइट हैंड साइड, देन दैट वुड बी डेक्स्ट्रोकार्डिया. एंड साइज क्या बताता है कि कार्डियोमेगली है कि नहीं. कार्डियोमेगली इज अ सेपरेट एंटिटी. विल रीड अबाउट कार्डियोमेगली व्हेन वी रीड अबाउट चेस्ट एक्सरे एंड कार्डियोवैस्कुलर रेडियोलॉजी. Second thing is cardiac silhouette is normal in position and size. Now, third thing that we talk about are the bilateral hyla. Bilateral hyla are normal in position and size. Just give me a minute. I think my phone got switched off. So let's. Third thing that we'll see are the hyla. Now, where are the hyla present? Hyla क्या होता है? Basically, hilum of lung. So this is the right hyla. I'll draw it here only. This is the right hyla. This is the right hyla and this is the left hyla. It basically hilum क्या होता है? जहाँ पे भी pulmonary vessels come and go, that is the hilum, right? Pulmonary artery and pulmonary veins, pulmonary arteries divide and pulmonary veins converge. That part is known as the hyla. Now, normal in position and size means position का मतलब क्या है कि कोई collapse या कोई पुल नहीं कर रहा है, फाइब्रोसिस नहीं है. एंड साइज का क्या मतलब है कि कोई लिम्फेडिनोपैथी नहीं है. देयर इज नो हाइलर लिम्फेडिनोपैथी. दिस इज व्हाट इज मेंट बाय पोजीशन एंड साइज. सो वी गो फ्रॉम मिड लाइन टू लैटरली. मिड लाइन में हमने पहले देखा ट्रेकिया, इट वाज मिड लाइन. हार्ट साइज वाज नॉर्मल, हार्ट पोजीशन वाज नॉर्मल, hyla was normal. Now from this we move on to cardiophrenic angle, sorry, costophrenic angle. These angles, these are known as costophrenic angles. Costophrenic angle. So fourth thing that we will write are bilateral CP angles are sharp. Bilateral CP angles are sharp. And this tells us that there is no pleural effusion. This tells us there is no pleural effusion. So clear है यहाँ तक? किसी को कोई डाउट है? Any doubt till now? So we have moved from trachea, cardiac size, hilum to CP angles. Next, we'll move on to the lungs. Finally, now we'll move on to the lungs. Fifth thing we'll write, bilateral lung fields are normal in volume and bronchovascular markings. Bilateral lung fields are normal in volume and bronchovascular markings. Now, what do I mean by bronchovascular markings? So let me erase some things. या फिर हम दूसरे वाले इसमें देख लेते हैं. Let's see in this X-ray. So can you see on this X-ray? There are multiple vessels. This is vessel, this is a vessel, this is a vessel, this is a big vessel, and multiple small markings are there. These are nothing but the bronchi and the pulmonary vessels in the lungs. So they should be seen like normal bronchovascular pattern. Sometimes what happens, आपको यहाँ पे dilated airways मिलते हैं. आगे हम देखेंगे bronchiectasis में you'll get dilated airways. So that thing has to be mentioned. That means that the bronchovascular markings are not normal. This is how normal bronchovascular markings look like. And finally, sixth thing, we'll look at the bones and soft tissue. Bones and soft tissue are normal. Bones and soft tissue are normal. Clear? So we first talk about the airways. Trachea is in midline, cardiac size is normal in position. Then bilateral hilar are normal in position and size. Bilateral CP angles are normal, and bilateral lung fields show normal volume and bronchovascular markings. This is the whole outline. This is the broad outline of our chest X-ray reading. Let's first come to the pathology of airways. Like first thing that we'll read about are airways. Now, can you see on this chest X-ray that this is the airway, this is the trachea. Can you see that the trachea is deviated to the right hand side? We'll call it right tracheal deviation. So how will I read this X-ray? This is a chest X-ray PA view of flana patient, aged flana ears, and the is the patient midline? No, the patient is not midline. This X-ray film is rotated. The medial end of clavicle is here, and this is the midline. So the film is rotated to the left. The film is rotated to the left. There is adequate exposure. It is a PA projection, and it is taken in end inspiration. Rest of the things are fine. Next, what I'll say is that the trachea is deviated to the right. I'll say that the trachea is deviated to the right. Cardiac size and position cannot be commented upon. Bilateral CP angles, the left CP angle is not visualized, and there is an opaque left hemithorax. There is an opaque left hemithorax. I write it opaque left hemithorax. And so what is the diagnosis here? There is right tracheal deviation and opaque left hemithorax. So something is pushing the trachea from on the left hand side. Most common cause is a massive pleural effusion, which pushes the trachea to the right hand side. I think मेरी बैटरी खत्म होने वाली है. Just give me a minute, I'll be back. Talking about right tracheal deviation, left opaque hemithorax, the most common cause of this is a massive pleural effusion on the left side. राइट. सो ये क्वेश्चन आएगा आपको डायरेक्टली. क्वेश्चन में आंसर यही देना है आपको कि ओपेक लेफ्ट हेमिथोरैक्स है विद राइट ट्रेकियल डेविएशन, समथिंग इज पुशिंग द ट्रेकिया टुवर्ड्स द राइट हैंड साइड. मोस्ट कॉमन कॉजेज ऑफ मैसिव लेफ्ट प्लूरल इफ्यूजन. Now, second cause, if some examiner is very inquisitive and wants to push you, आपका वाइवा अच्छा जा रहा है, right, and you have already said massive left pleural effusion, he'll ask, is there any other cause? And in any other cause, you will say, yes, a large left chest wall mass can also cause this picture. राइट. बेसिकली कुछ होना चाहिए यहाँ पे ना, इधर फ्लूइड होगा या कोई बड़ा सा मास होगा. दिस कैन ऑल्सो कॉज. थर्ड कॉज इज लेफ्ट लार्ज प्लूरल मास. This can also be an important differential of this left opaque hemithorax. So this is our first image and first spotter. Next is other similar looking images. So opaque hemithorax किसको बोलते हैं? One side of chest is completely white. Right. Now इसमें differential diagnosis बनते हैं after you see the tracheal position. Next step is to see the tracheal position. So पहला scenario is that trachea deviated to the same side as opaque hemithorax. मतलब जिस साइड हेमिथोरैक्स था उसी साइड ट्रेकिया डेविएटेड है. मतलब समथिंग इज पुलिंग द ट्रेकिया. व्हाट इज द कॉज ऑफ दिस? द कॉज इज lung collapse. Now second differential is that trachea is in midline. that this is the trachea. It is in midline. That means that this is a case of consolidation or collapse plus pleural effusion. A third scenario is trachea deviated opposite to opaque हेमीथोरैक्स कि ट्रेकिया हमारा राइट हैंड साइड पर है एंड हमारा इफ्यूजन लेफ्ट हैंड साइड पर है. इट इज ऑपोजिट. दैट मीन्स समथिंग इज पुशिंग. वी हैव ऑलरेडी रेड द डिफरेंशियल फॉर दिस. व्हाट वाज दैट? इट इज मैसिव प्लूरल इफ्यूजन. वी हैव टू से द वर्ड मैसिव. केवल प्लूरल इफ्यूजन बोलने से नहीं चलेगा. मैसिव pleural effusion. Right? So this was regarding airway. One question gets solved straight away here, straight by looking at this opaque hemithorax and tracheal deviation. Now, similar to an opaque hemithorax, we have something known as radiolucent hemithorax. ओपेक का मतलब क्या होता है? रेडियोलॉजी टर्म में, एक्सरे टर्म में ओपेक को बोलते हैं वाइट. वाइट को बोलते हैं हम ओपेक एंड ब्लैक को बोलते हैं हम रेडियोलूसेंट. सो वाइट विल बी रेडियो ओपेक एंड ब्लैक विल बी रेडियोलूसेंट. यहाँ पर क्या दिख रहा है हमें? दिस लंग, द राइट लंग इज अपियरिंग मोर ब्लैक एज कंपेयर टू द लेफ्ट लंग. सो आई विल कॉल दिस राइट रेडियोलूसेंट हेमीथोरैक्स. Right? And what am I seeing here? I am seeing that the trachea is deviated to the left hand side and there is this air containing, there is this air in the right lung, and can you see that the lung is now collapsed? What is this? This is right pneumothorax. Good. ठीक है डॉक्टर प्रवीण प्रसाद, दिस इज राइट न्यूमोथोरैक्स. ट्रेकिया इज डिवाइडेड ऑपोजिट टू द न्यूमोथोरैक्स. Now look at this picture. Lung collapse. Again the trachea is deviated to the side of radiopacity. रेडियोपैसिटी भी राइट साइड में है, ट्रेकिया भी राइट साइड में डिवाइडेड है. मतलब कुछ पुल कर रहा है उसको. व्हाट इज दिस? कोलैप्स्ड लंग इज पुलिंग द ट्रेकिया. एंड व्हाट इज द अदर pointer to a lung collapse? I can see that the minor fissure is pulled up. This is the minor fissure. Minor fissure is pulled up and trachea deviated to the right. So how will I describe this x-ray? This is a PA view chest x-ray of a 45-year-old male. The trachea is deviated to the right hand side. The cardiac size is normal in shape and size. Bilateral costophrenic angle or CP angle are sharp. I can see a homogeneous radio opacity. I can see a homogeneous radio opacity in the right upper zone, which is pulling up the right minor fissure. So what is my diagnosis? The diagnosis is right upper lobe collapse. Right upper lobe collapse. Now another thing that I want you all to remember are zones of lung. How do we localize? This is for localizing lung pathologies. Localizing lung pathologies, we divide the lung into 3 zones. So the upper zone is, this was the first rib, this is the second rib. So till the second rib, this is our right upper zone. Now from second to fourth, this is the third, this is the fourth. Till here, this is the middle zone. This is the right middle zone. And below that, we have the lower zone. This is the right lower zone. So upper zone, middle zone, and lower zone. This is how we divide the lungs into three zones. First, second rib, upper zone. Second to third and fourth rib, middle zone, and below fourth rib, lower zone. Remember, these are not lobes. This is not upper lobe, middle lobe, or lower lobe. These are zones: upper zone, middle zone, and lower zone. So we describe any pathology with respect to a zone. So for example, in this pathology, in this example, I'll say that this right homogeneous radiopacity is seen in the right upper zone. Okay. Now let's come to the various pathologies. How do they look like? So collapse we have already seen. It will be homogeneous and it will pull up the minor fissure. What will be consolidation? Sometimes you will see a homogeneous opacity with few fluffy radiopacity and one thing that is known as an air bronchogram. If you see an air bronchogram, that means it is a consolidation. Now, if you see a rounded homogeneous opacity, it is a nodule. If it is less than 3 centimeter and more than 3 centimeter, we call it a mass. It has to be rounded, all margins visible, well defined. Now, what is atelectasis? This is also known as lung collapse, and this is loss of lung volume. So you see it as a triangular radiopacity mostly. अपर लोब में है तो अपर लोब में ऐसा दिखेगा, मिडिल लोब में है, मिडिल लोब में ऐसा दिखेगा, एंड लोअर लोब में है तो लोअर लोब में भी ट्रायंगुलर ऐसा दिखेगा. दिस इज लंग कोलैप्स. एंड समटाइम्स यू सी स्मॉल फाइन लाइंस. These are interstitial opacities. These are interstitial opacities. Okay, so lung collapse and various other pathologies. We'll see all the various pathologies one by one. So in the first image, what do I see? I see that the mainly pathology is on the left hand side. How will I describe this X-ray? The trachea is in midline. The cardiac size is normal in position and size. Bilateral CP angles are sharp. Now let's come to the lungs. In the lung, I can see multiple variable size, round, fluffy opacities. We call them fluffy opacities. क्यों? क्योंकि इनके margins बहुत अच्छे से नहीं दिख रहे हैं. Hazy margins हैं, like cloud-like opacities भी बोलते हैं इनको. So we call them either cloud-like opacities or fluffy opacities, right? So multiple variable size fluffy opacities are seen in the left middle zone and left lower zone. So what are these? These are nothing but consolidation. This is consolidation. Now in the second image, how will I describe this X-ray? I'll say that the trachea is in midline. The cardiac size is normal. Bilateral CP angles are sharp. The main pathology is in the right upper zone, right upper and middle zone, in the form of a cavity. This is what is known as a cavity. Center में there is air and periphery में there is this consolidation. छोटा सा consolidation है. This is what is known as a cavity. And third is this X-ray. If I see a very rounded, well defined, I can see the margins of this lesion, right? This is what is known as a mass, lung mass. तो अलग अलग पैथोलॉजीज कैसे दिखती हैं? कंसोलिडेशन फ्लफी दिखता है. कैविटी में सेंटर में एयर होती है और पेरिफेरी में देयर इज रेडियोपैसिटी और कंसोलिडेशन. And mass is homogeneous, very well defined with all the outline visible. This is a lung mass. Okay. Now let's look at this chest x-ray. What do I see here? I can see that there is this small nodule in the right upper lobe. This will, I'll label this as a nodule because it is less than 3 centimeter. Less than 3 centimeter. Now, in this chest x-ray, what am I seeing? I am seeing that the bronchial markings are prominent in the right upper lobe. This is what is a picture of bronchiectasis. This is what is bronchiectasis, dilated bronchi. And here, what will I label these pathology as? So I can see multiple very well defined rounded masses. Some are more than 3 centimeters, so I'm calling them masses. Some are less than 3 centimeters, so I'm calling them nodule. So this is also a nodule slash mass. This looks like big, so this is a mass. So multiple masses scattered in bilateral lung feet. Yes, good Praveen. This I'll call it as mass. Multiple lung nodules and masses. Right? This is typical of मेटास्टैसिस एंड इसका एक नाम दिया गया है कैनन बॉल मेट्स. क्वेश्चन आता है विच ट्यूमर्स गिव कैनन बॉल मेट्स. टिपिकली दिस वाज डिस्क्राइब्ड फॉर कोरियोकार्सिनोमा, but they can also be seen in RCC, renal cell carcinoma, or any other tumor. But these two are named tumors for this cannonball beds. ठीक है. Now let's look at these set of chest x-ray. So what do I see here? I can see that the trachea is midline. Cardiac size is a little enlarged on the upper aspect. However, the lower part is normal, so the cardiac size is normal. Bilateral CP angles are sharp. Now let's come to the lungs. The main pathology is in the form of a thick walled cavity. This is a thick walled cavity in the left upper zone. I label this as, how will I describe this? Thick walled cavity in the left upper zone. Right? So this is a cavity. I'll label this as a cavity. That's all. Now, how will I describe this finding? I'll say that there is a cavity in the right upper and middle zone with air fluid level. देखो एक level दिख रहा है हमें यहाँ पे. Cavity in right upper and middle zone with air fluid levels, and this is what is typical of a lung abscess. अगर एयर फ्लूइड लेवल मिल रहा है कैविटी में तो आपको लंग एब्सेस बोलना है. अगर केवल एयर दिख रही है तो कैविटी बोलनी है. राइट? एंड अगेन दिस इज अ एयर फ्लूइड लेवल नहीं है, सीटी स्कैन है, ये केवल एयर दिख रही है एंड थिन वॉल्ड है. तो दिस इज अ थिन वॉल्ड कैविटी. सो क्लियर है सबको? प्रवीण, अब्दुल, कृष्णामूर्ति, मेडिको जर्नी, डॉक्टर जी, सब क्लियर है अभी तक? क्या पढ़ा है हमने? एयरवेज पढ़ा है, फिर लंग पैथोलॉजीज पढ़ाई, कंसोलिडेशन, कोलैप्स, कैविटी, लंग एब्सेस, कैननबॉल मेट्स. Right? And again, this is how consolidation looks like. So I can see here that there is homogeneous radiopacity in the right upper and middle zone, and the minor fissure is not retracted. I can see the minor fissure is here. What else can I see? I can see, if I zoom in, I can see few air bronchograms. So air bronchograms are hallmark of consolidation. And another appearance of consolidation are these fluffy opacities. So देखो यहाँ पे ill defined opacities हैं, these fluffy or cloud like opacities, these also represent consolidation. Which book to follow for radiology? So don't buy any new book for radiology. Read your coaching notes for radiology. So if you've taken PW MedEd, read the coaching notes that I have made for PW MedEd. They are more than sufficient for radiology. Okay. Now let's come to this image. So this is a X-ray of a child who has fever for 1 month. Now how will I describe this X-ray? I'll first see the age of the patient. This is a chest X-ray PA view of a let's say 3 year or 5 year old child. There is no rotation. There is no rotation. This is a PA view X-ray. Adequate exposure because I can see the intervertebral disc posteriorly, and it is taken in adequate inspiration. Now the main pathology, let's come to now the chest X-ray. The trachea is in midline, the cardiac size is normal, bilateral CP angles are sharp. The main pathology is in the form of these tiny millet shaped nodules, millet sized nodules, tiny nodules scattered bilaterally. देखो bilateral है, कोई zonal distribution नहीं है, scattered bilaterally throughout the lung. So the terminology is tiny millet sized nodules scattered in bilateral lungs, right? This is typical of miliary TB. This is typical of miliary TB. Now, the last X-ray that we will read will be that of TB chest X-ray, because TB chest X-rays are very commonly shown to you in the PHC settings, in your OPD. So you should know what findings are there in TB. So first of all, when do you say that it is an active tuberculosis? Active TB means that this patient has an active infection and needs treatment. He needs treatment and he needs isolation because he can also spread the TB bacilli to any other person. So what are the features of active TB? Number one is cavity or cavitation. Can you see this is a cavity here? This is a cavity. So first finding is cavity. Second finding are consolidations. Consolidation. Can you see these fluffy radiopacities? ये consolidations है. Third thing is nodules, right? Now nodules are better seen on a CT scan. They are better seen on CT. Now what are the nodules? See these tiny nodules. These nodules, यहाँ पे nodules है, multiple tiny nodules are there. Now these nodules have a typical name. This is known as tree in bud nodules. Tree in bud nodules are seen in tuberculosis and also other infections, but most commonly described for tuberculosis. It is seen in bronchopneumonia also, it can be seen in fungal pneumonia also, but if the examiner asks you one type of nodule, tree in bud nodule cause, it is tuberculosis that you have to say. Now fourth sign of active TB is necrotic lymphadenopathy. Write it अच्छे से, necrotic lymphadenopathy. And fifth thing is pleural effusion. Right now, necrotic lymphadenopathy कैसे दिखती है हमें? CT पे better दिखती है. So these are enlarged lymph nodes which are appearing hypodense. This is necrotic lymphadenopathy. And how will you see pleural effusion? Again, we know how pleural effusion is seen. It is seen as blunting of CP angle. Okay, blunting अगर हो रही है CP angle की, then that represents a pleural effusion. Now see this image. Can you see? These are the tiny nodules. These are tiny nodules that you can see, and they are appearing in a branch sort of way. राइट जैसे कि एक डंडी पे छोटी छोटी बर्ड्स निकलती है लाइक अ ट्री इन बर्ड लाइक दिस. So this is the appearance of tree in bud nodules, and this is seen in endobronchial spread of TB. Whenever the TB bacteria spreads via bronchi, it gives a tree in bud appearance. So very important to know the active TB findings. If you see cavitations, consolidations, nodules, pleural effusion or necrotic lymphadenopathy, you are dealing with an active TB, and this patient needs an ATT. So we read about cavities, lung abscesses, collapse, consolidation, nodules, masses. In the next class of Clinical Masterclass, we'll read about other findings on chest x-rays like interstitial diseases, and I'll give you some spotters and ask you how to diagnose this, right? So we'll wind up today's class on basics of chest x-ray here, and I'll see you guys in the next class. If you have any queries, please mention them in the chat, live chat, and I'll be happy to take them. If there are no questions, then we'll wind up today's session, right? So thank you so much, and I'll see you guys in the next class. Bye bye.